Dr. Becky Cooper.
Thanks so much, Sharon. Thanks very much for being here. I just want to follow up on my colleagues' queries around patient safety and just see if I can get a clearer idea about that. So when there was the mid-staff scandal, the inquiry found that restructures of the NHS services can create risks to patient safety. Now, NHS England wasn't responsible directly for patient care, but I wonder, with your expertise, whether you could comment on where the risks potentially are and whether you get a clear sense of how the department can help mitigate against those in partnership with, obviously, the ICBs and the rest of the healthcare service.
Yeah, so when it comes to the events around mid-staffs, I think there was a clear kind of concern about the relentless focus on finance and productivity, and that, you know, the voices and views of patients and families and of staff were not listened to, and because of that lack of responsiveness, horrendous effects were had, causing enormous harm to patients and death. And so, you know, one of the things I would like to point to is around how we're changing that culture. And with Martha's Rule, which is a pilot which has been running for the last year, and I've given the committee members an example of how many parts of the system need to work collaboratively together to make those changes happen. And, you know, what's been fantastic around this is that the engagement not only of family members being able to escalate concerns, and we've had over 2,000 calls which have led to more than 300 patients having an improvement in their care and over 100 ending up being escalated to ITU or equivalent. I think it really shows that the patients and families have really valuable information that we can listen to. And if we act on that, then we improve safety and we reduce, harm to patients, but also we improve things like staff morale, reduce numbers of complaints, etc. In my previous role, I was the National Guardian for the NHS and set up Freedom to Speak Up on the wake of the Francis report. And one thing I can say for certain is when change happens, people want to speak up. So I would really encourage all of those, whether that's in NHS England or in ICBs or in providers, to listen attentively to what their workforce are saying. And I know you're going to be hearing from workforce representatives later this morning, but also to be really acutely listening to what their patients are saying.
For the benefit of those at home, can you describe very briefly what is Martha's Rule and what we're seeing in front of us? Because we can't show them, so if you could just very briefly describe it.
So Martha's Rule is an initiative which was started after the tragic death of Martha Mills, and it's about giving patients and families the opportunity to get a rapid review if they're concerned about deterioration of the patient. It's been piloted in 143 hospital sites, and it's about giving the staff the ability to act on their clinical judgment, but also for patients and families, if they're concerned that they're not being listened to be able to get a review from a critical care outreach team. So this is something which I've been chairing the oversight group for this for the last year, bringing together dozens of organisations who've all got a really important part to play as representatives, as patient groups, but also for the professional regulators, officials, and the team at NHS England that have been leading the pilot.
Which is fantastic. So that's really helpful. Thank you. And you'll forgive me, but having been in sort of the health arena for 20 years, and I'm sure you guys have been there for quite a long time, none of this is new, what you're saying. It's all it's been around in various forms, probably for longer than 20 years, about how we listen to patient voice, how patient safety is very important. So I just want to go back to a phrase that I think, Sharon, you used around organisational memory. So with this reorganisation, in terms of patient safety, in terms of the duties that NHS England has, how is that organisational memory being passed on, or do you think we are in danger of reinventing a wheel again?
So we would absolutely urge not starting from scratch. Obviously, this committee is sitting before Wes Streeton speaks on the 8th, so he may well have a clearer transition plan, but we urgently need to know what a clear transition plan looks like. We need to ensure that the day-to-day is being done in that 2 to 3 year period, 2 year period where the transition will happen. And with regards to patient safety, I think you're right, we hear stories of care going wrong all the time. I mean, the one thing for mid-staffs, I think, to highlight is that although ICBs are facing a similar environment in terms of finances and push on elective care, there is a better patient experience landscape now in terms of collecting information. So the Friends and Family test came out of the mid-staff's review. It's not perfect, but it is a mass collection of people's experience of care. If I was to advocate for anything, in NHS England, they used to have a clear directorate just for patient experience, and then it got subsumed into the nursing directorate. There's an opportunity here to put a directorate back that leads just on patient experience to show that it is really, really important. Again, going back to the idea of accountability at an ICB level. But just one warning, we've absolutely got to ensure that we're hearing from a diverse community. Health inequalities are essential to the Labour manifesto, and also it's a core function of the ICBs. So we've got to be really careful how we're listening to patients. So, for example, we've gone out as National Voices to do some focus work on translation issues, and we had to go out into grassroots charity communities and hire a translator, an interpreter, to really understand their concerns. So doing everything online or doing everything on an English-focused app is not necessarily going to be the solution to hearing from concerns from everyone.
That's fine. Thanks, Chair. Thank you so much.
Dr. Becky-Cooper again.
Thanks so much, Chair, and thanks everybody for coming along. I should declare before I start asking my questions that I'm a member of the BMA, but Professor Banfield's, endorsement of public health, I've not bribed him to say that, so that's good. But I do want to talk about public health functions. I do think that there are many questions around public health and the implications of the reorganisation for public health. So I know the BMA has said that it has got concerns around the public health functions and the public health workforce. So just for the record, I think we should probably just point out that we had Public Health England, and then that splintered into the Health Security Agency and into the Office of Health Inequalities and Disparities, or Improvements and Disparities, and then the local authority function as well. So we've got that splintered make-up now. So I wonder, with your areas of expertise, if you could talk through the opportunities that merging DHSC and NHS England potentially bring for public health, particularly in that area of health inequalities, because we heard from the previous panel that was an issue, but also the risks that it brings to public health. And perhaps if you want to talk about the budgets as well, that would be really interesting. So shall we start with Jeanette first, if that's okay?
I think we all recognise that public health is the key way to improve the health of the nation going forward. That primary, secondary prevention, all of the health monitoring, but also all of the screening things. And as you've quite rightly pointed out, they've had a very rough ride recently and a lot of changes. And I think it's incredibly important that the part of the discussion around, there's a 50% headcount, we need to be absolutely clear about what, as I said before, what functions we want from the centre, what functions we need to be at the centre, and what that outcome looks like, and then build back the number of staff that actually needs to take it.
Just to be clear, Jeanette, do you think that the OHID should still remain in the centre as part of the Department of Health and Social Care? So that health inequalities and disparities piece, do you think that's best served in the centre?
I think I would defer to my public health colleagues on that, because I think there are pros and cons of everything, but I think it's about understanding the function needs to exist somewhere with a population-based oversight, a national population-based oversight. There's lots of different locale stuff, there's very much place-based stuff, but there is that national oversight needed.
Thank you. Nicola, Professor Ranger.
Yes, I mean, I think, where public health sits, obviously, is with the experts. But I think there's something for me around, we know since 2009, some of the key people for public health are people like health visitors, school nurses. They've reduced by 45% since 2009. They're crucial for those people in where communities are. We would love to see it incentivised, that some of those numbers go back up to that 2009 figure, even as a start. And we would like to see, nurses are the constant 24/7 presence in many areas. We would love a real focus on prevention and public health as part of their day-to-day lives and work. If we could just find a way, both as a profession, which we can do, and externally, to liberate nurses' time, they're a really good army of public health
Absolutely.
committed people.
And perhaps if I could just reflect something of what you were saying earlier around the current bizarre training programs for nurses where mental and physical health is separated. Would you see the public health function of that sort of more holistic training sort of very much being part of that redesign?
I would really like us to do it, and we're looking at that as a college. I think things are far too segmented. You've got one person in front of you with so many different needs. You need someone skilled that can assess what you need both now and in the future, what the problem is now, and I think we need to relook at the nurses that we are educating to really put the person at the centre. At the moment, though, I'm afraid nurses pick up too many jobs that other people don't want. They have too much bureaucracy. So I think in order to function as we want to for the public, we need to liberate their time in a slightly different way.
That's interesting. I might come back to that, actually. Professor Banfield, public health systems, where is the BMA?
I mean, look, COVID exposed just how fragmented, how dismantled public health had become. So splitting, a big chunk of public health away from the health service, we wasted billions of pounds that we didn't need to spend, and more people died than needed to because of that public health not being in the state that it should have been. And this is just an opportunity to repair that.
How do we not waste billions of pounds this time?
You can use that. It doesn't matter what structure you've got. If you've got the people there with the function to take that big picture view. I mean, inequalities in the population, inequalities in the workforce, valuing that and appreciating that diversity, protecting a large number of the workforce have disabilities. That public health function can do that. Enormous amount of public health prevention work goes on in general practice, nurses in general practice as well. So, this is a huge opportunity here to reset that.
Great. So if I can just move on with that thought, really. So thinking about that holistic health service provision and the staff and the staffing opportunities that are there as this new function develops. Professor Ranger, I wonder if I could come back to the comment that you raised earlier around nurses picking up roles and perhaps healthcare professionals picking up different roles at the moment. And I wonder if you could comment on perhaps the manager-clinician relation in staffing and how that works or doesn't work, and any thoughts as to how you think that might be more appropriately managed as we see the changes at the centre and ICB. So, Professor Ranger,
I think it's a really good time to take a really good step back and say what's good governance and what's bureaucracy. Clinicians are extremely good at knowing what they do that's complete and utter waste of time. Let's try and get people to work at the top of their licence wherever they are. We are quite risk averse, and actually to make a good patient decision requires a little bit of judgment and risk. And a lot of things is done by protocol, whether it's assessments, whether it's risk assessments, because people are scared of someone falling or not getting a DVT or whatever it is. So we're quite protocolized, which actually sometimes takes a lot of time. And some things are essential, but some things could be stripped out. And it feels to me like a good time to take a look at everyone seeing what they're doing now and what they'd love to be doing for their patients. And because I think we've got to work differently. And some of that is about risk and people being understandably defensive in how they practice, because actually it can be tough if you make a mistake, but that takes a lot of time. And I think that would free up clinicians really being able to do what they know is right for patients.
Okay, thank you. Jeanette, any thoughts?
I think management is not something that miraculously appears because you're a clinician. I think you really need to be trained for it, and you need to be trained well for it. I think there is an absolute value to having clinician managers because they see the full picture, the nuance of the sometimes unintended things that happen. But I also think that in many roles this is not an incentivised role. It's not supported. You wouldn't in an industry take senior clinicians, ask them to do management and not support them, not train them, not support them, not provide coaching or whatever for them to do their best job. And most managers in medicine and nursing and the healthcare services generally, they retain a clinical role and flip in and out of clinical and managerial roles. There are a few who continue to be pure managers, but most flip in and out of those clinical roles, so they go back to being within their clinical group. So how you prepare that clinical group to be managed and to accept management and then to move on, I think is a really important thing that we don't focus on enough, I think.
Thank you, that's really valuable, and I suppose as the centre rearranges itself, it will be, as you say, an opportunity to perhaps revisit some of that. So my final query, and Professor Banfield, I'd like to come to you on this, is I am very keen on institutional organisational memory, and yourselves, you've been in this longer than I have, but there have been, as you've previously said, several reorganisations, and so I would just like to hear your thoughts about what lessons you would urge the government to draw from previous attempts to reorganise the NHS, particularly with regard to managing the impact on staff and staffing. So, Professor Banfield, I'm going to start with yourself.
Well, it's going back to basics, isn't it? Start defining what you want your health service to deliver, defining where your priorities are. Is it the elective service? Is it the emergency service? How are you going to transition from hospitals to community? So having that overall picture and then using the expertise that will help you get there, because sometimes you're going to need to speak truth to power. It's going to cost you more to do it that way. But what we need as a service and as a country is long-term ambition and long-term investment, not short-term kind of political papering over the cracks. But it's, fundamentally, this is an opportunity to change the culture of the NHS. We've heard this morning about patients and listening to patients. Now, that's not just about how your health service is organised, but when you're a medic, the doctor will tell you what's wrong. The patient will tell you what's wrong with them. So just listening to them, they'll tell you when what you're doing is wrong as well. But we're still in a system that blames the individual on the end of the mistake. We're in a safety critical industry. Stuff goes wrong all the time. It is amazing the amount of harm and error that we trap every day. All right? So the making sure that the advocates of the system needing to learn are still in place, still being heard, because what we get, and there have been very high profile examples, is we have an NHS that feels that it has to hide stuff or it has to look after its own bit of an organisation as being open and transparent. And this is the opportunity to reverse that and to listen to the concerns of both staff, doctors, nurses and patients.
Excellent, thank you. So a learning system sounds very wise. Just to pick up on, and you have said this a couple of times actually, about what the NHS is there to do and what we're there to deliver. So I think that's a fairly comprehensive answer. So do you, in your expert opinion, when you go to your respective jobs, when you speak to the people, are you very clear about what the boundaries are for the National Health Service in terms of what clinicians are there to deliver, how we are there to deliver it, or does it feel that it's an ever expanding? We're sort of, we're doing a lot, as I think Professor Banfield said, with not enough, and it's not clear where those boundaries are. I don't know if I've phrased that correctly. Does that make sense?
Do you want to start?
Well,
Sorry.
I may have misunderstood your question, but I think at the moment, I think what people need is a bit of hope, actually. And at the moment, what they are doing, they want to be doing well. And even if you extend out, extending boundaries, I think at the moment people just even want to be able to do the basics well.
Yeah.
And I think that is what this reorganisation has got to do. Patient satisfaction in the NHS is the lowest since we've measured it. actually. People are looking for more private healthcare than they ever have. Staff are a little bit fed up and demoralised. The best thing this reorganisation could do is start to improve on some metrics, even if it isn't everything. Because what people are starting to do is a little bit of faith in the NHS, both the staff and the patients. That will be a disaster. So whatever they decide to, whatever is decided centrally and with clinicians and providers, what needs to get better, let's get it better. Because at the moment, almost everything is struggling.
Yeah, that's interesting. Thank you. Jeanette, any final thoughts before I hand back?
Yeah, I think Nicola's got it right. Patients need to feel that the NHS will be there when they need it. The question is, we ration as we're doing already, we just are slightly quiet about it, and we're uneven about it, and we're inequitable about it. Mm-hmm. Can we deliver everything for every person in the population? No. Yeah. But how do we deliver the best care we can with the money we have? And that's about enabling clinicians to do their job by providing the basics, which is good staffing, good infrastructure support to do that, and a culture that learns and understands and doesn't blame individuals.
Excellent. Thank you, Chair.
Thank you so much. Well,